Welcome. This is a really important session in terms of taking time out to share ideas and information as a core value that senior psych cares in terms of the need to listen, learn, and share information. And we certainly believe that the impact of telemedicine on long-term care is something that's worth discussing because it is here to stay and it's going to continue to evolve. So if we can all start collaborating on those ideas, it's going to be a very, very rich and efficient component of our care practice. I'm Leilani Doyle, Director of Education Awareness for Senior Psych Care, and I'm joined today by Coy Nguyen, who is the Business Direction Officer in the South region. Coy has really helped get the telemedicine program off the ground for senior psych care, and he has been instrumental in this session. And I'm also joined by Sebastian LaRouche, who is the Regional Director for the Houston area, South Texas, Diego Basagoja, who is the Director of Business Operations for Senior Psych Care, and that title does not do Diego justice. He is really a very strong talent in the area of compliance and understanding the impact of telemedicine on all aspects of long-term care facilities, payer validation, and regulatory items. So we're very lucky to have Diego on here. I'm here as the Director of Education Awareness, the least important person in the room, but all the panelists are here to share their experiences. They are in the field day in and day out, hitting the ground and understanding a lot of activities there. I did want to go back to this slide because we really believe that there is no greater honor than to care for the very young or the very old. I want to take a pause, and everybody on this call is participating in this care in one way or the other, and oftentimes you don't get recognized. So I want to give everyone here on this call the recognition you deserve and to share that we are with you because our mission is to create a better quality of life for seniors, for the staff, and their family. There's nothing more important to us. So we're happy to be a part of this. One of the things that we found ourselves, when we think back to the beginning of 2020, my goodness, can any of us think back that far? But if we do think back that far to 2020, how we have changed and adapted our facilities, our processes, our practices, our staffing requirements. It has been very impressive in terms of the adaptations we've had to make. This is a really good picture about how things have happened recently, but in the beginning, it was a challenge. And so Coy, I was hopeful that you could come in and say a few words about what you've seen. I know you've been there from the beginning in terms of when the crisis hit, how we were putting things together the best way we could, and share some insights about the facilities that you were visiting and caring for there in terms of routines or practices that we followed.
Hi everyone, this is Coy. So when COVID started, the patients, they really needed us, but the doors were locked. We couldn't get in. They were very depressed. They weren't able to do their regular routine, which caused them more depression and anxiety. So with the development of our telemedicine kiosk, it really got our foot in the door and got us to those patients so we can help them and meet their needs, take care of the depression before it escalates to a higher level.
Because it not only impacts the patients, but it also impacts the facilities, because when it hit, it was an absence of guidelines or protocols, and they were struggling to do the best they could. And I know you mentioned the kiosk, but before we had the kiosk, because this took us all by surprise, SBC has been doing a serious telemedicine component for a while. So we had experience in using other devices. Were we able to turn that switch pretty quickly in terms of getting our practitioners over to using it? Or what was the communication like between senior psych care and the facilities?
With the facilities, they told us that we couldn't come in, but we could perform the telehealth. We did have one facility before COVID that it was a larger facility, and we had our prototype there, our prototype telemedicine kiosk. And what we did is we developed a better one that worked easier for the patients, and we tried to just stay ahead of the game so we can keep seeing those patients and taking care of their needs.
Yeah, I think staying ahead of the game is the key factor, and getting protecting our providers as well as protecting staff and patients is a key component to our core. But I know we were stuck in balancing the physical and psychological health of patients. The facilities had physical health was, of course, on the top of mind, but without the proper psychological care. And as you mentioned at the beginning, there was a lot of confusion, depression. People were without their standard routine. They didn't see their therapists coming in on a regular basis. They couldn't visit their families. So it must have been quite a time to be able to introduce some new technology, which we all know technology takes a while to get used to behind that.
There's some patients that they didn't want to use it, but I would go in the room with them and explain it to them and kind of help them use it. And with that, they enjoyed the device better. And our speakers are really good for the hard of hearing. So the hard of hearing patients, they were taken care of, because with the prototype, that one didn't have the best speakers, and the hard of hearing patients had difficulties.
Yeah, that is a really good point, because I know a good number of facilities use their existing equipment or are using cell phones, and that certainly has some deficits behind that. But in terms of providing that consistent continuity of care that helps maintain order in the facility, I know we were able to achieve it, but was that something that we have a practice on, a pacing between face-to-face visits and telemedicine visits?
Yes, we have a hybrid solution to that. What we do is our mid-level providers do the face-to-face sessions, and then the MDs would do the telehealth sessions, because they have more homes, which means they would do a lot more driving. But with the telehealth cart, they'll be able to see the patients very easily. On the telehealth kiosk, you're able to send messages to anyone at the nursing home, send meds, reports. So it actually makes it easier for the doctors.
Yeah, I think you were telling me when we were planning for this webinar, the discussion where you got, everybody involved to make sure there wasn't any, conflicting medication or conflicts with diagnosis and the medications that were being prescribed. Can you relate that story? Because I thought that was a very impactful story that you shared.
What I would do is about 2 days before the session, we would contact the DON and go over all the patients and get a good status over them, so the doctor would have a good overview. And then we go over with each nurse all the patient's medications and test scores, vitals, labs. That way we'd be completely prepared. We also had a tech on the other side that would bring in the patients to the kiosk, like a clinic.
So that really helped assist the facilities in attaining their goals in terms of medication management and GDR rates and all those things that, goodness, I know during a crisis, they kind of take, second fiddle to dealing with the immediate action at hand. But that process was proving helpful for the facilities.
Oh, yes, ma'am, because it kept everyone on the same page. That way, if something was going on, it was documented. We knew what we needed to do, how to take care of it, if the patient was taking the meds, or if we needed to try something else. And it kept the DON in the loop, which really helped.
And the end result was we had I think the facilities reported, I know some of the facilities I've had the pleasure of meeting with firsthand reported lower hospitalization rates, which was a good thing, because in the crisis environment, the last thing you want to do is send patients that could be treated in the facility safely to a hospital.
Yes, we prefer to do in-house treatment. That's why our plan is the weekly visits followed by the doctor's routinely visits, so that we can catch it before it escalates, so you don't have to.
And thank you for sharing that. I'm going to ask Sebastian to join us and talk a little bit about the telemedicine rapid response, because I know that we've got more numbers kicking back up. One of the things we did, and Coy mentioned that we had a prototype of the kiosk out there, but we, Senior Site Care saw this need. We had relied on the experience and the building blocks that we had to have a rapid response. And I know, Sebastian, you are out there in the field delivering devices and responding there. So I thought it would be a good time for you to weigh in on the use of our various techniques for conducting telemedicine, how they've been received, and what you see as perhaps the future based on your experience and actually being at the facility.
Thank you, Leilani. I appreciate being on the call today. Without a doubt, we have a big task at hand, really, which is how are we meeting the mental health care needs of our seniors? And that really requires a coordinated system of support and services that are not only delivered to them in a timely fashion, but that are effective and appropriate. And telemedicine really has become that tool during this time where we're really being able to integrate our services in a way that has not been done before. We're able to not only use telemedicine to provide increased access to care, really in underserved communities, at homes who are in need in quick response, but it also allows us to continue that continuity of care, right? To look across the board, how are we going to continue to provide services? Specific to your question on the rapid response, we've had plenty of situations where facilities will, we'll go in 1 week and a couple of days later, a new patient has come on board and they need to be seen quite quickly. Because we no longer have that geographic limitation, we can set up a telemedicine call for that 1 or 2 patients that maybe are new to the home that need a rapid response and a rapid clinical evaluation. And we're able to then determine the level of care that's necessary and see what needs to be done so that when we go back in the following week and we follow up with that patient, the patient is already being taken care of, already stabilized, and already being seen by our services.
Well, that does seem like a really valuable service. I know we're talking about senior side care, and this is not meant to be a promotional webinar at all. I think when you share your real experiences, it makes it very tangible, and we clearly have the experience. I know at some point during the crisis, we were up to well over 25% of all of our visits were being conducted through telemedicine, which shows our dedication in getting this service provided there. But clearly face-to-face helps in so many ways, and when we can be there, we want to do that face-to-face visit. But I know there's other kinds of technology out there as this crisis has continued and as facilities have become aware of what's out there in the market. We are very responsive in using different adaptive or available technologies within the facilities. I know we had a big review of the kinds of telemedicine that was being conducted just so we could understand the demands there. If you could share a little bit about how you've seen the different kinds of devices used at different facilities. Some are more, I know the SAM, which is our portable kiosk, which is very good and adaptive to viewing is good, but others are using FaceTime or existing tablets there. So maybe you could share what you've seen out there in facilities today.
We've definitely seen a variety of services in the past that have included FaceTime, like you mentioned, Doxy.me, some other platforms. But what we found is when we are using technology such as the carts or using the Microsoft Teams network, is that we are able to really go just that one step further, because we're able to integrate them more into the relationship, which is an ability to communicate during the call and off the call. And I know Diego will talk about it a little bit down the line on the virtual health network and where we are there. But what we see out in the field is really this, we use the technology that's available to us. When one technology is not available, we're able to pivot very quickly. We find that in homes that have a SAM or have a tablet that's separate from the one that they use for patient visits, for family visits, that not only do we get to spend more time with the patient, obviously improving quality of care, and we're also able to provide a different level of service, I guess, when you have a dedication to having someone facilitating the facility.
Yeah, I think that's a wonderful thought. And I know you and your team have delivered some of the SAMs. One of the things that we noted early on when we were rolling the program out was the need for training, because this was all new. We introduced it like in the spring last year, so everybody was still learning about it. How do you go about the training? What's involved, and how long does it take to do that kind of training?
Before we go out to do the training, we always have a kind of a pre-deployment meeting, in a way, speaking with the person that we're going to be connecting with at the home, usually the administrator, director of nursing, or the social worker, who will kind of give us expectations on what's their time frame that they're available to work. And then we kind of work a little bit together on what is their operational workflow, so that we find already a plan that's in place. Before we even go out to the facility, we just kind of discuss on how they work, what their needs are, and how can we meet them. And then we also talk about, of course, IT. You have an IT component to this. And so before we even go out there, we already have all that information, so that when we are at the home, the implementation, the deployment process really should not take very long, because we've already established our workflows and we've already established our IT requirements. So when we get there, we set up the tablet. I think it would maybe take about 15 minutes or so when we already have that information. And then we always like to do a education. And so because a lot of times we don't want to be in the home unnecessarily, try and keep everybody safe and clean and protected, we do this outside of the home many times. And what we do is we kind of run through the process of how to connect, how to disconnect, how to communicate. We'll invite a couple of the different nurses, so that everybody, even though they may not be using the cart themselves, they know what the technology is, they know how to navigate it. Should they ever have any questions, there's always someone in the home that can kind of jump in and quickly turn on the device and make it available. The good thing is we do not have to have a nurse per se or a clinical staff member moving the cart around. That facilitation can be done by really anybody. In one home, there is even a kitchen staff that in between breaks has said, oh, I can help and move the cart around.
It's absolutely wonderful how everybody's pitching in to help. And I think training outside the facility, that's brilliant. And because we're in the Texas area, usually have good weather. So that's a real plus behind that. But it's certainly that prep work seems like a best practice for any facility that's looking to expand their telemedicine reach, or get that in place. Having that pre-training process is critical to the success. And I think you hit on a really great point there. I know that we were talking about facilitation of visits and all of that, but I think that's just one step in the evolution of telemedicine. And Diego, I'm going to call on you to talk more about this, because I know you have that solid vision. You've experienced it firsthand in terms of some integrations we've done with other larger facilities, multi-location facilities. And I think it's something we've been listening and waiting for a lot of years. So I thought I'd let you talk a little bit about what you see in terms of the evolution of telemedicine, where it's going, and how we might deal with the compliance aspects of it.
Thanks, Leilani. To pretty much go ahead and paint that whole picture, many of us have probably already dealt with telemedicine in some format by now. And really the big thing to understand is that 2020 has been a year of pretty much rolling back all the red tape, greenlighting everything, and trying to create adoption. So with that said, we know there's going to be changes in 2021. This has all been for the national health emergency, right? The pandemic, COVID-19, has really caused all of this to pretty much speed up the process of the adoption of telemedicine, something that, people thought was going to take 10 years. We did it in 6 months. So those are the expectations that we've seen during the pandemic. Now, it's also important to know that this telemedicine, telehealth, there's various words that you can use for this, it's not a replacement of the face-to-face visit. This is really to complement that and to continue maintaining the continuity of care approach. It's ideal for preserving the patient-physician relationships. So those are the types of ideas you really want to have in mind when you're thinking about what is this going to be for long-term care? What do we see it as compliance? What do we see this for billing in going forward in 2021? We have the first set of rules coming down from CMS for January 1st, 2021. I do expect us to start seeing some of the red tape come back. A lot of the temporary use codes are probably going to go away. I don't know to what extent. There hasn't really been much feedback on that just yet, but there will be a lot of changes on how we use telemedicine, and it's imperative that everybody continues to stay current with the information coming down, because ultimately it is still new and it is still important for us to keep moving forward and understanding whether or not there is a limitation. And as far as we've been able to tell here at Senior Site Care, is that the type of care that we provide via telemedicine is extremely similar to that of face-to-face, which means that we are not sacrificing our quality when it comes to telemedicine.
That's wonderful. I think that's very insightful in terms of there are changes that are coming, and facilities and providers alike need to be prepared. I'm sure payers have been pretty on board with the changes that are coming. Have you noticed any difference in the payer network or the coding requirements there?
Right. So the payers are beginning to change their ideas. CMS is a little bit slower. However, the payers, think about United Healthcare, Amerigroup, Molina, et cetera, all of these entities are beginning to have their own set of rules on whether or not they're going to, give you some examples. Are they going to continue to expand the origination fee, right? Are they going to continue to pay at the same rate as a face-to-face visit? These are all questions that are constantly being floated by them today to really start creating a type of fee schedule going forward of what they believe is the value of telemedicine, the value of these origination fees, and putting that in terms of contractual obligations that many organizations deal with these payers. CMS, as I said, they're a little bit slower. They're still working through all the data they've collected, and I'm sure it won't be much more until they start going and pretty much stating their stance on how telemedicine is going to be for the future.
Great. So I know we've been talking, the whole first part was dealing with the visitation and facilitation of visitation, which is critical, no doubt, in terms of a crisis environment. But I did hear Coy and Sebastian touch on this extension beyond just visit facilitation. Could you maybe share a little bit of what you see or what you're planning for? Because I know you've got a very good vision about where things are headed.
So as I mentioned, the future of healthcare has gone from a 10-year type plan to 6 months, and it's constantly changing right now. And what I see is the adoption of technology is becoming extremely important for the best quality of life we can provide to the patient. It's about the accessibility, it's about the convenience, it's about maintaining the safety. We are still in this pandemic and COVID is not going away. So it's important to really address all of these components and understand that as we keep pushing forward, we need to look at maintaining high quality, HIPAA protections. Are we taking the right steps to make sure that we are maintaining the expectations, not only as a practice as a whole, but are we maintaining the expectations for the patient, right? When you talk about technology in the patient's world, or in this case for long-term care, what does that mean for quality? It's not all about just the telemedicine visit. It's also about how can you go ahead and meet the commitments, the service commitments, right? So we talk about visit notes in long-term care. We talk about, is the patient getting the medications? We talk about what type of the MDS coordination and all that stuff. What are their scores? What's going on in terms of the patient's day-to-day? Are they having activities? Are they becoming more lethargic? All that type of information is about trying to put it all in a single location and be able to transfer that data back and forth for the benefit of the patient. So it's important to create a network of sorts, and that's what we've been striving for with SPC. It's about creating this virtual network that we really want to go ahead and be able to send information back and forth faster than we've ever sent before, because with the technology component, things move a lot faster, which means that you can now get the information almost instantly. Before you had to you had paperwork, you had different levels, different groups of people, but with technology, you start skipping a lot of that, and that really helps move forward the quality.
It seems hard to believe that, in this day and age, we are still, or were still very much paper oriented in many of these facilities. But when you move to this technological solution, there's certainly an element of professionalism that we have to achieve. I know that you've been instrumental in working on getting senior site care accredited as a telemedicine provider, which is not an easy task. And there's a lot of things to consider. I shared a slide from the URAC, the accreditation organization, They have some very good outline procedures. I don't think we need to go through all of them. I think it's important to touch on the fact that we are thinking through what these are, and the facilities that are listening on the phone today need to consider that this is something when you're implementing your network and implementing a solution that ought to be considered with the highest quality of care when you're looking at really using that technology in an expanded way, because I do think that's the future, and being able to connect network to network is going to make things so much easier, more efficient, and give better patient care in the end. So maybe we could say a few words about the accreditation process.
So the reason we've been pursuing this is, aside from it being a very high quality of telehealth and networking, it's important to know that, again, we've been functioning in 2020 without the red tape. 2021 will be different. The only thing we've been told for 2020 is try not to use TikTok or any of these public-facing video applications, right? So they've been very lenient. They're not using fines if you're using Facebook Messenger or WhatsApp or FaceTime. But eventually, these things will be rolled back. It was all about getting the adoption set up in place. Our pursuit of getting accredited is about showing that we are meeting all the expectations, making sure we have systems in place, protections in place, that we are analyzing everything being done. We are getting the information. We have proficient training and providers in this whole network aspect. And the idea is to really push this as a whole network approach versus just a singular telemedicine visit. Many of us have probably dealt with the HIE, the Health Information Exchange. So it's similar to that, but this is more of a servicing network versus just a push of information back and forth with data, with patient health information.
That's great, and I think it's something we all need to be aware of. And Diego's so happy that we're making efforts and great strides in getting this done. I think it is a good benchmark for us to use, a good gold standard to measure by. And I think that is a information worthwhile sharing to our broader audience. Is there a timeline anticipated for this?
We are already getting ready to submit all our paperwork and all this stuff to get the accreditation started and getting that set up for us. As far as our network that is already in place, we are already using it in certain facilities, and as far as it's been going, it's been extremely positive. We've been able to alleviate a lot of the stressors from facilities who are part of this network now. We do expect it to continue growing in that sense.
That is huge. When anytime you can help the facility, because goodness knows they are doing their best in the toughest of times. And I'm so grateful that we're able to help. One of the items I wanted to touch on, because I've seen this in a review of our statistics, is the impact on the smaller facilities or rural communities where access to broadband internet or other technologies is not there. Their facility is lacking the ability to, or the technology in-house to do that. But surely there must be some help with the payors and the government, everyone trying to facilitate this to keep everyone safe. What kind of help is out there for small and rural communities?
Right. So in this day and age, meaning 2020 and going forward, it's important to note that telehealth is no longer a luxury, it's a necessity. So what does that mean for the smaller rural communities that have never really gotten the funds or the telecommunication companies to be able to go out there and give them the speeds they need? The government pretty much has made a lot of adjustments and changes and has provided different forms of getting funds to these facilities. You can try civil money penalty funds. You can try accessing through your the MDS format, things like that. There's ways to go ahead and push to get some funding. Some of the other items is these origination fees. So for every telemedicine, and telemedicine is both currently, because of the pandemic, both video and audio together or audio only, is allowing for these origination fees, which is about $20 on average per visit. So these are funds that you can use to continue to make a difference on the infrastructure of your facility, to get increased bandwidth from the local service provider. And it's about trying to work with what you can in your rural markets. Now, there is other organizations that are also flooding these markets with money. So I believe Verizon and AT&T are beginning to try some rural funding of getting services further out. So these are entities that you eventually want to work with and see if they're willing to fund some of your costs to really bring you up to speed with bandwidth usages, as that's been the biggest issue in rural communities.
Absolutely. And let me just clarify, I know you touched on origination fees. Were you saying that, just by facilitating the telemedicine visit, whether it's an audio only or audio and video, use whatever device, internal device, external device, there's additional fees that the facility can collect directly? Because I know we handle most of the billing for our services. Is that what I heard?
Correct. So with the origination fees, the facility can go ahead and bill just like any ancillary service. So if you've ever billed for a flu shot, it's the same function. There's nothing different there. You're taking the data service of the visit, the patient name, and then the provider information who provided the service. You send that to CMS or one of the other payors, and they'll pay the origination fees. Now, the expansion of that goes all the way until December 31st, 2020. It will probably be limited again coming to 2021. However, I do not see the payers or CMS or Medicaid for that matter really cutting back too much in this area, as they have seen a large need to provide additional funds to keep telemedicine going. But I do see some slight changes. I don't see them to be heavy though.
I think that's a great benefit for facilities. We're always looking for funds, and I'm so glad you brought that to everyone's attention here. I did want to speak just a little bit about coding correctly for billing and payers. I know that's something that we can track through our telemedicine capabilities. Is there anything that we haven't already touched on that you'd like to mention here? Because I know that is something that getting the right codes in helps facilitate all these billing activities.
Right. I've been working very closely with a lot of our facilities that we do telemedicine with, and I do assist their billing departments to go ahead and bill for these services. So when it comes to the origination fees, as I mentioned, you'll need the data service, the patient name, the provider who provided the service, as well as knowing that the code is the Q3014. Those are the types of things you'll send in with your CMS 1500 form and send off. When it comes to the clinical side, so meaning our provider who's servicing, the main thing is, in mental health, the CPT codes for the most part have been there pre-pandemic, so there really wasn't much of a change there. The biggest change really was the place of service, which has changed to 02. The facilities that I'm working with, what we do is we provide the services to them, and probably a week later or 2 weeks later or whatever cycle we choose, I assist them by running some reports in our system and giving them information so that they know what patients they can bill for, so they can get the origination fee and collect on that, so that they have additional funds to work with.
Perfect. That's the wonderful service. And the last thing I wanted to touch on is our COVID-19 responsiveness. I know we had, during the summer, we had some breaks and homes were opening up, and that was a good thing. But lately we've seen some, changes in lockdowns, or homes that are open and they go into lockdown. So I just want you to touch on a bit about our COVID responsiveness and how long it takes to get something, in the facility, how quickly we can, help. I know there's some rural communities out there that are really struggling, that weren't hit hard, like some areas that we were already dealing with, and they're being hit hard now. So I thought it might be helpful to touch on, what the onboarding looks like for new facilities, and our time to onboard, which I know is a lot of times driven by the facility.
I mean, we all know that COVID isn't going away, and it seems numbers are coming back up, and states are beginning to lock down again, or counties locking down. So we're seeing that same pattern again that occurred earlier this year. This time, however, I believe a lot of organizations are prepared for this. Here at SPC, we are very prepared for it. We have multiple ways to adapt very quickly when this happens now. And you're showing on the screen the time to onboard with a new facility. So the quickest way we can onboard a new facility, of course, will be via telemedicine. We work through the contracting, we get a device out there, we give credentials, we process the patient information, which can be done as quickly as same day for the urgents, and really get processes going through there and then get the clinicians set up. The process to onboard and provide telemedicine services is extremely fast versus the face-to-face. And the main reason for that is that we're not dealing with a logistical component. We're not talking about distance of driving and things like that. We can remove that factor and really speed the process. When it comes to the implementation part, we have at SPC multiple ways, and with various facilities, we've actually integrated in our virtual network of sorts in different methods, whether we provide credentials or we begin to whitelist services because we have similar licensing with the facilities, which allows us to really connect and become more in sync with one another and really provide patient health information back and forth at a significantly faster pace than we've done previously.
So I'm looking at this, and I think that's wonderful that we can do that. And you were so spot on in terms of no longer being limited by geographic boundaries, which we all know is a barrier for psychiatric care, psychological care in the rural or smaller homes. It doesn't mean they don't need it. It just means they lack access to it. And certainly our mission to provide improved quality of life for all seniors, it hits home to that mission. And I think this is a wonderful, wonderful process that we put in place. If I'm looking at the pie chart that you showed, it looks like the majority of the time to onboard is, of course, getting the contract in place. And I know that's likely based on normal circumstances. If we were able to get a contract in place within a day or so, how soon would it be for a clinician to be out there and engaging with a potential problem or disruptive patient or resident within the facility?
Right, so if we get the contract pretty much within a day, you're talking about, let's say we get it Monday and possibly by Friday you're being serviced. We're talking about speeds of that nature. The most difficult part in this will be what does the IT infrastructure look like, right? And there's a lot of workarounds with that, which is nice. Technology is about having the options, right? And then this really gives us options. So with that said, you're talking about 4 to 5 business days, let's say, is what you're looking at if you're getting same day or within 24 hours a contract signed and sent back and getting serviced.
That certainly would be hugely helpful. I know in speaking to facilities out there, when they are in need and their current provider, local provider may be unable to service. I think that's a critical care, and I'm so proud to be part of an organization that can be that responsive. Certainly we are here to help. I wanted to thank, we're getting close to the end of the webinar session. I wanted to thank everyone for attending and listening, and I want to thank our panelists, Coy, Sebastian, and Diego, for contributing your wealth of knowledge behind this. We're always here to help. So if you have any questions, please feel free to reach out to us. You can contact our CARES hotline at the number listed below, or by sending email to spccares@spchealth.com. We have a solid service level of agreement to do that. And if you reference this webinar, you'll be given priority access to SAM, which is our mobile device that was referred to in this, our cart that was referred to numerous times in this presentation. Although that's not the only way we deliver telemedicine, it certainly can be responsive and has the improved ergonomics designed for many of those seniors in your facilities. So I did again want to thank everyone. Please watch for our next webinar. We'll be having a wrap-up session, close out 2021 in December. We'll hope to make that fun and inspirational so we can just reflect back on all that we've achieved and move forward into 2021, because 2021 has got to be a lot better than 2020. So I thank everyone, and we'll look forward to talking to you again in December.